Welcome to Pediatric Case Review. Today we will explore infectious mononucleosis in pediatrics. This lecture provides a comprehensive overview of the condition, focusing on practical approaches to diagnosis and management that pediatric clinicians can apply in their practice. We will cover the pathophysiology, clinical presentation, diagnostic approaches, treatment options, and important complications to watch for in children with this common condition. A 14-year-old patient presents with fatigue, sore throat, and fever for 10 days. What is the most common cause of infectious mononucleosis? Is it A. cytomegalovirus, B. Epstein-Barr virus, C. Toxoplasma gondii, or D. human herpes virus 6? Consider the typical etiologic agents that cause this clinical syndrome in adolescents. The correct answer is B. Epstein-Barr virus. Epstein-Barr virus causes 80 to 90% of infectious mononucleosis cases. It is a member of the herpes virus family that establishes lifelong latency in infected individuals. Other less common causes include cytomegalovirus, which accounts for 5 to 10% of cases, human herpes virus 6, and adenovirus. Understanding the primary causative agent is essential for appropriate diagnosis and management of this condition. A concerned parent asks how their teenager contracted mononucleosis. What is the most common transmission route for Epstein-Barr virus? Is it A. blood transfusion, B. respiratory droplets, C. contaminated food, or D. oral contact/saliva? Consider the typical ways this virus spreads among adolescents and young adults. The correct answer is D. oral contact/saliva. This explains why infectious mononucleosis is often called the kissing disease. Saliva is the primary vehicle for Epstein-Barr virus transmission, which can occur through kissing, sharing utensils, or drinks, and prolonged close contact. The disease peaks in adolescents and young adults, with 90% of adults worldwide showing serologic evidence of past infection. Once infected, the virus establishes lifelong latency in the host. Which cell type does Epstein-Barr virus primarily infect? Is it A. neutrophils, B. erythrocytes, C. B. lymphocytes, or D. hepatocytes? Understanding the specific cellular target of this virus is fundamental to understanding the disease pathophysiology and the characteristic laboratory findings seen in infected patients. The correct answer is C. B. lymphocytes. Epstein-Barr virus enters through the oropharyngeal epithelium and primarily infects B lymphocytes via the CD21 receptor. These infected B cells then trigger a T-cell proliferation response, which actually causes most of the clinical manifestations we see in infectious mononucleosis. The virus establishes lifelong latency in memory B cells, allowing it to persist in the host indefinitely. This understanding of the pathophysiology helps explain why we see the characteristic laboratory findings like atypical lymphocytes, which represent the activated T cells responding to the infected B cells. A 16-year-old presents with a 7-day history of fever, sore throat, and fatigue, which is not part of the classic triad of infectious mononucleosis. Is it A. fever, B. pharyngitis, C. cervical lymphadenopathy, or D. petechial rash? Consider the hallmark clinical features that define this condition and help distinguish it from other illnesses. The correct answer is D. petechial rash. The classic triad of infectious mononucleosis consists of fever, pharyngitis, and cervical lymphadenopathy. While petechial rashes can occur in some cases, they are not part of the classic diagnostic triad. Other common symptoms include fatigue, malaise, and headache. The incubation period is typically 4 to 6 weeks. It's important to note that the presentation varies by age, with the classic triad being more common in adolescents than in younger children, who often have milder or atypical presentations. Infectious mononucleosis presentation in young children most commonly includes: is it A. typical triad with positive heterophile test, B. milder symptoms, often misdiagnosed, C. frequent hospitalization requirement, or D. prominent exudative pharyngitis? Consider how the age of the patient affects the clinical presentation and diagnostic approach to this condition. The correct answer is B. milder symptoms, often misdiagnosed. In young children, infectious mononucleosis often presents with milder symptoms or may even be asymptomatic. Preschoolers typically show nonspecific fever and upper respiratory infection symptoms rather than a classic triad. Additionally, heterophile antibody tests are less reliable in young children, making diagnosis more challenging. In contrast, adolescents are more likely to present with the classic triad of symptoms, more severe manifestations, and have higher heterophile test sensitivity, leading to easier diagnosis. This age-related variation in presentation is crucial for pediatric clinicians to recognize. A 15-year-old presents with fever, sore throat, fatigue, and lymphadenopathy. What is the most common location of lymphadenopathy in infectious mononucleosis? Is it A, inguinal, B, axillary, C, posterior cervical, or D, supraclavicular? Understanding the characteristic pattern of lymph node involvement can help distinguish infectious mononucleosis from other conditions that cause similar symptoms. The correct answer is C, posterior cervical. Posterior cervical lymphadenopathy is highly suggestive of infectious mononucleosis and is a key physical finding that helps distinguish it from other conditions. The lymph nodes are typically firm, tender, mobile, and often bilateral. They may be quite prominent in some cases. Other important physical examination findings include pharyngeal inflammation, tonsillar enlargement, and palatal petechiae, which may be present in some patients. Recognizing this characteristic pattern of lymph node involvement can significantly aid in the clinical diagnosis of infectious mononucleosis. A 14-year-old with confirmed infectious mononucleosis wants to return to sports activities. What percentage of infectious mononucleosis patients develop splenomegaly? Is it A, 10 to 20%, B, 30 to 40%, C, 50 to 60%, or D, 90 to 100%? Understanding the frequency of splenomegaly is crucial for appropriate management and activity restrictions in these patients. The correct answer is C, 50 to 60%. Splenomegaly develops in 50 to 60% of patients with infectious mononucleosis, typically peaking during the second to third week of illness. Importantly, splenomegaly may not be palpable in all cases, and ultrasound may detect subclinical enlargement. The spleen usually returns to normal size within 4 to 6 weeks. This finding has critical implications for activity restrictions, as splenomegaly increases the risk of splenic rupture, which, although rare, can be life-threatening. Therefore, patients should avoid contact sports for a minimum of 4 weeks, even without documented splenomegaly. A 13-year-old presents with a 5-day history of fever, sore throat, fatigue, and lymphadenopathy. What is the best initial test for infectious mononucleosis diagnosis in adolescents? Is it A, complete blood count with differential, B, monospot/heterophile antibody test, C, Epstein-Barr virus viral capsid antigen IgM, or D, throat culture? Consider the most appropriate first-line diagnostic approach for this common clinical scenario. The correct answer is B, monospot/heterophile antibody test. The heterophile antibody test is the best initial diagnostic test for infectious mononucleosis in adolescents, with 85 to 90% sensitivity in this age group. However, it has lower sensitivity in young children. This test is rapid, inexpensive, and serves as an excellent screening tool, though it may be negative early in the illness. Supporting laboratory findings include a complete blood count showing lymphocytosis with atypical lymphocytes and liver function tests that are often mildly elevated. Epstein-Barr virus-specific serology can be used for confirmation when needed. If the heterophile test is initially negative but clinical suspicion remains high, it should be repeated. Complete blood count results from a suspected infectious mononucleosis patient. What percentage of atypical lymphocytes suggest infectious mononucleosis? Is it A, greater than 5%, B, greater than 10%, C, greater than 20%, or D, greater than 50%? Understanding the significance of atypical lymphocytes in the complete blood count is important for the diagnosis of this condition. The correct answer is B, greater than 10%. Atypical lymphocytes are larger than normal lymphocytes with irregular nuclei and abundant cytoplasm. These cells represent activated T cells that are responding to the infected B cells, serving as a key marker of the immune response to Epstein-Barr virus infection. Atypical lymphocytes usually appear by the second week of illness and may persist for weeks after clinical recovery. They typically peak at levels between 10 to 30% of the total white blood cell count. While the presence of atypical lymphocytes is supportive of the diagnosis, they are not specific to infectious mononucleosis and can be seen in other viral infections as well. A 12-year-old presents with infectious mononucleosis-like symptoms but has a negative monospot test. What is the most common alternative diagnosis in this scenario? Is it A, streptococcal pharyngitis, B, cytomegalovirus infection, C, toxoplasmosis, or D, adenovirus infection? When the heterophile test is negative in a patient with symptoms suggestive of infectious mononucleosis, clinicians must consider other potential diagnoses that can mimic this condition. The correct answer is A, streptococcal pharyngitis. Group A streptococcus is the most common bacterial infection that mimics infectious mononucleosis, presenting with similar symptoms of fever, sore throat, and lymphadenopathy. It's important to consider this diagnosis, especially when the heterophile test is negative, because streptococcal pharyngitis requires antibiotic treatment. Other viral causes that can produce a mono syndrome include cytomegalovirus, acute HIV infection, human herpes virus 6, and adenovirus. Less common considerations include toxoplasmosis, rubella, and rarely, leukemia or autoimmune disorders. Clinicians should maintain a broad differential diagnosis when evaluating patients with mononucleosis-like symptoms. A 15-year-old with confirmed infectious mononucleosis and severe sore throat. What is the mainstay of infectious mononucleosis management? Is it A, acyclovir for all patients, B, supportive care and symptomatic treatment, C, corticosteroids for all patients, or D, prophylactic antibiotics? Understanding the appropriate management approach is essential for providing optimal care to patients with this condition. The correct answer is B, supportive care and symptomatic treatment. The mainstay of infectious mononucleosis management is supportive care, which includes rest with gradual return to activities, adequate hydration, and analgesics or antipyretics for fever and pain. It's important to avoid aspirin due to the risk of Reye syndrome. Antiviral medications like acyclovir are not routinely recommended as they provide limited benefit. Corticosteroids should be used selectively, not for all patients, primarily reserved for complications like airway obstruction or severe hematologic issues. Antibiotics are not indicated unless there is a concurrent bacterial infection. Special considerations include monitoring for airway obstruction, managing severe hematologic complications, and preventing splenic rupture through appropriate activity restrictions. A 14-year-old presents with suspected streptococcal pharyngitis. Which antibiotic should be avoided if infectious mononucleosis is suspected? Is it A, penicillin, B, amoxicillin or ampicillin, C, azithromycin, or D, cephalexin? Understanding medication contraindications is crucial when managing patients who may have infectious mononucleosis, as certain antibiotics can cause characteristic reactions in these patients. The correct answer is B, amoxicillin or ampicillin. These antibiotics are associated with a diffuse maculopapular rash in greater than 90% of patients with infectious mononucleosis. Importantly, this reaction is not a true allergy, but rather related to an interaction between the virus and the drug. Patients who develop this rash can still receive penicillins in the future if needed. This reaction can also occur with other beta-lactam antibiotics, though less commonly. The rash typically appears 3 to 5 days after starting the antibiotic. For this reason, clinicians should avoid empiric amoxicillin when infectious mononucleosis is suspected and should consider alternative antibiotics or await diagnostic clarification before prescribing. A 16-year-old with infectious mononucleosis is experiencing right upper quadrant pain. What is the most common serious complication of infectious mononucleosis? Is it A, splenic rupture, B, airway obstruction, C, hepatitis, or D, Guillain-Barré syndrome? While infectious mononucleosis is usually self-limited, it's important for clinicians to recognize and monitor for potential complications that may require specific management. The correct answer is C, hepatitis. Mild hepatitis occurs in 80 to 90% of patients with infectious mononucleosis, making it the most common serious complication. Laboratory findings typically show mild transaminase elevation, usually 2 to 3 times the normal upper limit. Severe liver involvement is rare. While hepatitis is common, other complications are less frequent but potentially more serious. Splenic rupture, although rare at less than 0.5%, is life-threatening and requires immediate intervention. Airway obstruction is also rare but represents a medical emergency. Neurologic complications such as meningitis and encephalitis can occur but are uncommon. Hematologic complications, including cytopenias, may also develop in some patients. A 14-year-old athlete has infectious mononucleosis with no palpable splenomegaly. When can contact sports typically be resumed? Is it A, after fever resolution, B, 2 weeks after symptom onset, C, 4 to 6 weeks after symptom onset, or D, after normal liver function tests? Understanding appropriate activity restrictions is crucial for preventing serious complications in young athletes with infectious mononucleosis. The correct answer is C, 4 to 6 weeks after symptom onset. Activity guidelines for athletes with infectious mononucleosis recommend no contact sports during the active illness, with a minimum restriction period of 4 weeks, even without documented splenomegaly. Many clinicians consider performing ultrasound in athletes before clearing them to return to sports. A gradual return to full activity is recommended rather than immediate resumption of full participation. Safe return criteria include being afebrile for at least 1 week, having no clinical evidence of splenomegaly, resolution of fatigue, and normalization of laboratory values if they were initially abnormal. This conservative approach is justified because the risk of splenic rupture persists, subclinical splenomegaly may be present, and the peak risk for rupture occurs during the 2nd to 3rd week of illness. In conclusion, Epstein-Barr virus is the primary cause of infectious mononucleosis in children, though presentation varies significantly by age, with younger children often showing milder or atypical symptoms. Diagnosis requires both clinical assessment and laboratory testing, primarily using the heterophile antibody test in adolescents. Management is primarily supportive with selective intervention for complications. Important considerations include avoiding ampicillin and amoxicillin, implementing appropriate activity restrictions to prevent splenic rupture, and monitoring for potential complications. Thank you for watching this pediatric case review presentation. Please follow our channel for more informative content, and feel free to comment with any questions you may have about infectious mononucleosis in pediatrics.